afternoon, everybody. We're just on about 10 past 12, so I think we'll make a start, make best use of the time. Welcome to this afternoon's breakout session on the Covid-19 public inquiry, what we know and how your organisation might be affected. For those of you who don't know me, I'm Miriam Deacon. I'm Director of Policy and Strategy at NHS Providers, and I'm going to chair this afternoon's hour-long session. So my main aim is to make sure as many of your questions are answered. And hugely warm welcome to my colleague Liz Hackett, who is a partner at Hempsons, and they're our partner in delivering this session today. Liz has 2 decades of experience of advising providers in healthcare advice and litigation. Her priority practice areas are inquests, inquiries, statutory and non-statutory investigations. And having heard Liz speak on the inquiry previously, I know she'll be able to answer any questions that you have in detail. So just to tell you a little bit about NHS providers' work around the COVID inquiry, we know that it's a priority for our members because you've told us that, and we've surveyed you on what you want from us over the course of the inquiry. So you've told us that your trust will be following the course of the inquiry as we'd expect. Actually, about 2/3 of you said that you're already looking at your evidence base and your data, which is interesting, your documentation, so you might want to speak to Liz about that and the likelihood of providers being called or otherwise. That might be a good topic for us to cover. Your key concerns, you've told us, are around supporting your staff during the period of the inquiry, particularly if there's negative narrative in the media. You've told us that you want the good practice, which emerged during the lockdown period, to be identified, as well as the things that could go better. You don't want to be waiting too long for learning, so you want to see the inquiry publish interim reports, which is something we've emphasised with the inquiry team, and you want us to brief you members on progress. So this session really is another in a series of webinars and briefings that we've been holding for our members in particular to understand what role they may or may not play as the inquiry unfolds. So in terms of the format, I'm going to hand over shortly to Liz, who's going to take us through a few slides through various aspects of the inquiry, and then we should have plenty of time for your questions at the end. If you want to ask a question at the end, please just raise your hand. We've got some mics that will go around the room, or if you would prefer, as we've got on the slide, you can use the Glisser platform. So just log in via that hashtag there, or you can use the QR code. You click on now because we're in session to add your question. And unless you particularly want to remain anonymous, please add your name and organisation so we know who you are as well. And your questions will come up seamlessly and I'll select them from the iPad in front of me. So lots of ways to interact. So without further ado, I'm going to hand over to Liz. Thanks, Liz.
Hi everybody, it's nice to see such a good turnout for this session, and I think it demonstrates the interest that there is across the healthcare sector for what is going to be a challenging few months ahead, grappling with what is expected of you and your organisation for the public inquiry. In terms of what we're going to take a look at today, we're going to do a little bit of scene setting. I'm going to take it that there's a mixed audience, some of you who I'm sure will have some in-depth knowledge of public inquiries, but I'm sure there'll be some of you who perhaps don't have that experience. Worry not, I'm not going to turn it into a legal lecture, but we are going to explore what a public inquiry is and what we know about the COVID-19 inquiry so far, and look at some of the legal powers that arise by virtue of it being a statutory public inquiry, because only understanding that information are you going to be best placed to be able to consider some of the strategic objectives that you may have for the coming couple of years. We're going to leave some time at the end, not just for questions, but if there's anybody within the audience who would like to share any discussion points or any reflections on their own experiences of public inquiries, then we would always welcome that. It's really important that you start talking to your peers as we navigate our way through the coming months and years. So, firstly, we're going to look at what a public inquiry is. We're going to take a look at the scope and the purpose of a public inquiry, and we're going to look at how a public inquiry works. And we're just going to cover these in outline terms, but if you want more information, pop along and see me later on today or tomorrow. Inquiries take different forms, as I'm sure you're all aware. We have statutory public inquiries, Grenfell, the infected blood inquiry, the inquiry into the events of Mid-Staffordshire, the Francis inquiry, as you'll all know about it. But then, of course, we have non-statutory inquiries, Morecambe Bay probably being the one that you're all most familiar with. And then, of course, we have different quasi sorts of inquiries. They all take a similar shape and follow a similar format. But what's important to understand is that the Covid-19 inquiry is going to be a statutory inquiry, and therefore the Inquiries Act 2005 is going to apply to that. And what that means is that the inquiry team will have legal powers in terms of disclosure. They will have ability to compel witnesses to give evidence and determine what's public. And there are some limitations that can be set in terms of government control of that inquiry. So it's an important primary consideration in terms of how you're going to plan moving forward. Now, a public inquiry is an inquisitorial process. Some of you may raise an eyebrow when I say that, and some of you who've been involved in other inquiries may not feel that it always is inquisitorial. But primarily, it's about doing three things. It's about establishing the facts, looking at why events happened, and significantly to learn lessons for the future. There is no power available to hold individuals or organisations to account in terms of civil liability or criminal liability. But it's important, I think, that we all understand the context of a public inquiry in that it is a fact-finding process. So there will be determination of facts. There will, therefore, potentially be some adverse findings of fact. And there will be an exploration as to why those events happened and how they happened. And those findings of fact can, of course, inform other proceedings, other investigations, and it's important to bear that in mind as you comply and engage with the inquiry as we move forward. An inquiry can only look at the things that are contained within the scope, and the scope is determined by the terms of reference. And we're going to come back and look at the terms of reference, particularly for Module 3, which is going to impact health and the healthcare sector. And it's really important that you bear at all times those terms of reference and the scope of the inquiry in mind when you are going through the process of dealing with any requests for disclosure or any requests for information. It's important to note, I think, that final point, that lessons learned for the future are at the very heart of a public inquiry. And you'll all be familiar with that there have been significant changes that have been brought about as a consequence of public inquiries in the past. If you think the Shipman inquiry and the changes that were implemented as a consequence of the Shipman inquiry to the death certification process, a process that we still see to this day. So you can see that significant and important changes can be made. In terms of how an inquiry works, a brief summary set out on the slide there for those of you who are not familiar with the process. And you'll see that the first step is always the appointment of a chair, and we know that Baroness Hallett has been appointed to chair the Covid-19 inquiry. The terms of reference are set, and that, of course, has been done, and it's been done in consultation. Some of you may have engaged in the public consultation that took place. And then there's an indicative timetable that's set. And what we know, what we are told, is that procedural hearings have already started. We know that. And we are told that substantive hearings of evidence are going to start as early as spring of next year. And that this is not going to be, we are told, a drawn-out inquiry. Again, those of you with experience of public inquiries will know how long they often can drag on. Also part of that preparation process is core participants being determined, and I'll come back to core participants, particularly with a focus on Module 3 in due course. We then move on from the preparation to the evidential stage, and this is when you will start seeing requests for information being made. There are then experts and policy professionals who are instructed, and information is considered and analysed in preparation for the public hearings. Once the public hearings take place, we're told that there will be draft interim reports published. But before any report is published, we go through what's called the Maxwellisation process. So anybody who's a core participant will get to see a draft of the report prior to publication. But it's not to correct the report, the findings of the report, it's only to correct factual inaccuracies. So the core participants don't get a heads up in that regard, but they will have an idea as to what's going to come. And then we will see the publication of reports and recommendations contained therein. So that's a really brief summary of how a public inquiry actually works. So now let's go on and take a look at the terms of reference, the modular approach that we're told is going to be adopted in relation to the Covid-19 inquiry. Significantly for all of you in this audience, Module 3. The methodology that we've gleaned is going to be applied, and some issues in related to data sharing and collaboration. I've already told you that the purpose of the inquiry is to establish the facts, look at why events happened, and to learn lessons for the future. And the Covid-19 inquiry is going to be no different to that. There are effectively two aims of a public inquiry, and two aims, therefore, for the Covid-19 inquiry. The first is the retrospective. It's that purpose of examining the impact of the pandemic and producing that factual narrative as to what happened and why the events happened. And they're the three broad areas that the inquiry is going to look at: the public health response, the response of the health and social care sectors, and the economic response. The second aim is going to be the prospective approach, and that is going to be to identify those lessons that can be learned to inform preparations for future pandemics across the UK. And a summary there, if you're not familiar with the module approach that's been adopted by the Covid-19 inquiry. Module 1 is alive and kicking, and that's going to look at the resilience and preparedness of the country for the pandemic. And in that regard, we've had procedural hearings, we've had requests for disclosure already made of various agencies involved, and also notably the government, and we're told that public hearings for that module are going to start in the spring of next year. Module 2, that's been the most recent module that there have been procedural hearings in respect of, and that's going to look at the core political and administrative governance and decision making across all 4 of the devolved nations, with public hearings starting for that, we're told, in the summer of 2023. Now, the headline one for all of you in this audience, Module 3, is going to examine the impact of COVID-19 on healthcare systems, on patients and hospitals and other health providers. We've got some outline guidance with regards to Module 3 already, and we are told that there will be procedural hearings in respect of Module 3 starting in early 2023, and we're going to come back and look at Module 3. Next year, there'll also be announced some additional modules, and some of those additional modules will impact on the health and social care sectors. They're going to look at both systems, and they will look at impact of the pandemic, and they will include things like therapeutics and vaccines. And then we are told that reports and recommendations will be made. There will be regular reports, so there will be interim reports. We're not going to wait right until the end of the entire public inquiry to draw to a conclusion. You will see chapter-based or module-based interim reports being published, with the implementation of recommendations that are contained in those reports being monitored thereafter. And I think that's a really important step as we move forward. It's okay to make recommendations, but we need to ensure that those recommendations are fully implemented by those who are impacted by them. So what do we know about Module 3? This is what Baroness Hallett, Chair of the Inquiry, said when she opened Module 3, and she only opened Module 3 last week. So relatively hot off the press, but I'm sure that you've seen some of the comments that she's made. Baroness Hallett recognises the unprecedented impact that the pandemic's had on all healthcare systems. And she's going to look at those decisions that were made during the pandemic and the reasons for them, with a focus on learning in respect of future issues that may arise. She has already started a process of listening. She's listened as she's been around the country over the summer. She's listened to bereaved families. And she's also listened to the impact that the pandemic has had on healthcare workers. And that listening exercise is going to continue right through the COVID inquiry. What we don't know yet is the degree of detail that Module 3 will go into. But I think what we do understand from the shape that has started to take place with regards to Modules 1 and Modules 2 is that there will be an analysis of the systems issues and the generic themes, and that whilst there is going to, of course, be this parallel listening exercise, we are not going to be looking at the individual patient care elements for those who were under your care during the pandemic. So here we go. Module 3 opened 8th of November 2022. And this is what we are told that it's going to look at. It's going to look at how healthcare systems responded to the pandemic and the impact on services and systems. And importantly, that's going to include the impact on patients, on doctors, nurses, and other healthcare staff. So your workforce is going to be at the heart of some of these considerations. It's going to cover all areas of healthcare, so primary healthcare, secondary, tertiary sectors and services. There are going to be some illustrative accounts looked at, and it will be interesting to see the guidance on that in due course and what those illustrative accounts are going to look like in terms of where is the inquiry going to go, who are they going to ask to present those illustrative accounts. And of course, inequalities will be at the heart of Module 3, just as it will be at the heart of all of the COVID-19 inquiry. If you haven't looked yet, go on the COVID-19 website and take a look at the 12 areas of investigation that are going to be considered. We call these CLOEs, key lines of investigation. So when people start talking to you about the CLOEs, then these are the things that are going to be looked at in detail. And they are really wide-reaching. They cover things such as core decision-making and leadership during the pandemic. They're going to look at the 111 and 999 and ambulance services. They're also going to look at the systems used during the pandemic, including the establishment of the Nightingales. They're going to, in a very broad sense, look at the provision of healthcare treatment. And that's going to be everything from how we manage patients under our care to DNA CPR decisions, to palliative care, discharge decisions. There is going to be a look at the prevention of the spread of COVID and communication with loved ones about their family members when they were in your care and they were unable to come in and visit. So it's going to be incredibly wide-reaching, and you'll need to explore those 12 key lines of inquiry so that you can see what impact those key lines have in terms of your organisation. There will be things that will jump out of that list that you will see are particularly specific to some of the challenges that you faced during the height of the pandemic. So as you start to work through that list, and as you see how evidentially challenging it might well be, you're going to start thinking about your documents and what have you got, and are the COVID inquiry going to start asking you for your data, for your information, in relation to those key lines of inquiry, so they can start building a factual narrative around each of those. I'm sorry to say it's the million-dollar question. I don't know how much information they're going to ask from each of you as individual providers. But what we do know is that there will be a role to some degree for all healthcare providers. And it may be that some data has already been centrally provided and collated, but there may be additional data that is sought in due course. What we also know is that if you want to be a core participant in Module 3 of the COVID inquiry, and we'll have a look at what that really means, is that we need to be looking at those key lines of inquiry now and understanding what you think your role, the role of your organisation may be evidentially in terms of responding to those key lines of inquiry, because the deadline for applications for core participants closes at 5 p.m. on the 5th of December. And that is indicative of the sorts of timeframes that public inquiries can often set. We are told and we are promised that there will be an attempt to prevent duplication of information. And I think the inquiry was very clear in opening all of the modules that there would be a review of existing research, and there would be a focus on commissioning research into areas where new academic analysis is needed, and there will be the appointment of scientific and other experts. So there is a means already identified as a way of collating information out with of coming to all of you as individual providers for your responses. So there is likely to be a parallel data collection process. We also know that there will be some regard to international comparisons where relevant. Disparities and inequalities, again, will be at the heart, along with listening to those who have been affected. And we know that the evidence will be heard, the oral evidence will be heard by a panel of 3 members. And there will be interim reports produced along the way. So in terms of the basics of the legal powers of the inquiry, I told you that this was a statutory inquiry and that there are powers, therefore, that arise as a consequence of that in relation to compelling organisations and individuals to provide information to give evidence. So it's important to really understand what might be requested of you and of your organisation. And here are the headlines as to the key legal powers. Rule 9 of the inquiry rules. This will be the first indication that your organisation may get that you are being asked to provide information to the COVID inquiry. And a Rule 9 request could be a written request for a statement, or a request for production of documents, or any points of clarification. And public inquiries do strive to collate all of their data via a Rule 9 request. However, if an individual or an organisation fails to comply with a Rule 9 request, then there is the fallback position of Section 21 of the Inquiries Act, by reason of this being a statutory public inquiry. And this gives the inquiry the power to serve notice on an individual or organisation to give oral evidence or produce those documents. And why is it important? Well, because if you receive a Section 21 request and you fail to comply with the Section 21 request, there are sanctions that are available to the inquiry under Section 35. And just so that you're aware of those, and I hope that nobody will ever find themselves faced with a threat of a Section 35 sanction, but it means that if that you're guilty of an offence if you fail without reasonable reason to do anything required by a Section 21 notice. Also, if you distort, alter evidence, again, something that I hope we will never come across, and it can result in a fine. It can also result in imprisonment, and depending on where you are in the UK, I think the highest is in England and Wales, 51 weeks. So just so you understand the powers and the sanctions that are available. However, if you're a registered healthcare professional yourself, and of course your workforce, there are some additional professional responsibilities that you need to be mindful of, both in the GMC code and in the NMC codes, to cooperate fully with the inquiry. And they're similar to the requirements that we see under Rule 9. A long list there of what are documents, what is it that you might have to provide to the inquiry. I am sure that I have missed a whole raft of information off that list, but you will see how wide-reaching a document is when the inquiry starts talking about requests for disclosure from organisations, right down to emails, Teams chats, WhatsApps, texts, diaries, calendars, etc. So if any of you have been following the inquiry, you'll also be aware that some of that level of detail has already been gone into by the inquiry. Boris Johnson has already been asked for copy WhatsApp messages during the pandemic. But I think what it does is it emphasises to you what a vast amount of data you are all going to hold that could potentially be requested by the inquiry, and I say potentially be requested by the inquiry pursuant to a Rule 9 request. So having looked at those introductions, having set out the framework by which a public inquiry works, it's important, I think, now to take a look at some of the really important things that are going to affect your decision-making over the coming months, and some of the really important strategic considerations that you may have. Preparedness. A number of steps really do need to be taken, and really do need to be taken now to ensure that your organisation is in the best place that it can be, and be best prepared as it can be should you receive a Rule 9 request from the inquiry in due course. And it was interesting to hear Miriam say that the information that the NHS providers have gleaned is that a large number of you have already taken a number of those preparatory steps. But it's really important, and the reason why we've covered those earlier slides, is that when you're thinking about and planning for what you're going to do next, that you do so in a way that reflects a knowledge and an understanding of what your legal and professional responsibilities and duties are going to be as the inquiry takes shape, and equally those of your workforce. So with that in mind, you need to start planning, and if you have not already done so, I can only emphasise that there is a need to do so now. If you remember back to June of last year, you will have all received an e-bulletin, I think it was, from NHS England, in which they set out a number of preparatory steps and recommendations that you should have all been taken. I know a lot of organisations have taken those steps, but I am aware that a number of organisations are yet to take those preparatory steps. Things such as issuing stop notices to your workforce, a means of just simply telling your workforce what their legal duties and their professional duties may be with regards to data, to ensure that information and data is preserved. Making sure that you've got somebody in your organisation who is an inquiry lead, who can lead on communication moving forward, if there is any, with the inquiry team, with other stakeholders, and who can be responsible for ensuring compliance should you receive those Rule 9 requests, so that you don't then go on to get a Section 21 notice. Some really simple things were recommended, like making sure that you have up-to-date contact details for senior individuals and personnel who were working with you during the pandemic. Those key decision makers who may have left the organisation or were not directly employed by the organisation. We all know how difficult it can sometimes be just to track somebody down. And when you're up against time pressures, the last thing you want to be doing is running around doing admin. And then the fourth preparatory step, and one that I've been working with a lot of providers on recently, is starting that process of document collation, so that in the event that you do get served with a Rule 9 request for disclosure, you're in a position to respond to it, and in a position to respond to it in what will be, without question, a relatively tight time frame. If you haven't already done so, and something that you really must do at a strategic level is to consider, as I said, those 12 key lines of inquiry that the module 3 of the inquiry is going to look at. That way you're going to be able to identify what role you may have and how significant a role and how significant a data set you may have in terms of the information that the inquiry team will be looking for to produce that factual narrative. And that question of core participant status, I saw a few eyebrows raised around the room when I said, well, you've only got till the 5th of December to consider whether that's going to be you. That's a really tricky decision to be made. I don't for 1 minute imagine that the inquiry is expecting every healthcare provider to be applying for core participant status. That would just simply be overwhelming. And what we can see from modules 1 and 2 is that there has been a knockback on a number of core participant applications. To be a core participant, what you need to be able to demonstrate is that you or your organisation played a direct and significant role. Well, that goes without saying for all of you in relation to Module 3. That you have a significant interest, and again, it goes without saying for all of you, and that you may be, or that you may be, should I say, subject to explicit or significant criticism. It's about thinking laterally about the role that you played in the inquiry. Were you gold command, perhaps, for your region? Or was there a particular impact that is going to be looked at in terms of those 12 key lines of inquiry that you know that your organisation may be at the forefront of? Tricky conversations, but conversations and thought processes that need to be had now. And simply what it means is that if you're a core participant, you will have the right to electronic disclosure. You will have the right to make opening and closing statements. You will have the right to suggest lines of inquiry during the course of the inquiry and the public hearings. But you will have to bear your own costs. And quite often people say, why on earth would I want to be a core participant anyway and raise my head above the parapet? But only you will know when you have done that analysis of the 12 key lines of inquiry as to how impacted and how central your position is going to be. I'm going to look at some strategy points, just moving on to the next slides. And it's about having your strategies and your planning in place now. It's about having resource and developing that resource. It's about understanding and recognising human impact. It's about looking at how we can ensure that your local community has confidence in your organisation. It's about ensuring that you are candid in your approach. The best way to best preserve your reputation as an organisation is to be candid. It's about parallel and subsequent investigations and making sure that you know what else is going on in terms of inquests and claims and what data may be available there. And as I look around, we have got some of our media colleagues with us, but you will get some interest from the media as the inquiry gathers momentum. So it's understanding how you are going to collate and respond to those in a consistent way. So if you haven't already done so, in terms of resourcing, there are a number of steps that you should be taking and thinking about. You need to appoint a board-level director, somebody with oversight and with accountability within the organisation. Then you need to appoint an inquiry lead. This is going to be the person who's going to engage and interact with the inquiry, with other stakeholders, and is going to lead your response to compliance with any request that you may have. It's important to identify steering groups. Who needs to be on your steering group? IT, for one. If you haven't already thought about it, speak to your IT departments as a matter of urgency, because we all know that we go through these processes of updating our data systems, data migration, and how difficult it can be to find historic documents and data that we're looking for, but also somebody from human resources within that team, so that we can communicate best with our workforce and keep people informed. Somebody perhaps from your EPRR team. What I've certainly discovered is that those who had a good EPRR structure during the course of the pandemic are best placed to pull all of this data together in a structured and clear way. Have communication procedures and have mechanisms in place for managing your documents, proper structures. How are you going to pull that documentation together? How are you going to store it and manage it? Because in due course, you may have to make disclosure to the inquiry. They will dictate, of course, what they want, albeit we don't have a data disclosure protocol from the inquiry for Module 3 at this time. And you need to look at what data you've got. How are you going to pull it together? How are you going to catalogue it, knowing what those 12 key lines of inquiry are going to be? Who are going to be your key players if you're asked for a witness statement dealing with some of the issues identified in those key lines of inquiry? And what are going to be your processes for check and challenge and for audit? Think about what requests are also coming in parallel to that. There will be requests coming in from national bodies, from regulators, from patients, from other organisations. And it's important to consider the legal basis upon which any requests for data during the inquiry are made under, whether they're under the NHS Act, whether they're Freedom of Information Act requests. We all know that the moment this process gathers momentum, you will see an increase, if you haven't already seen an increase, in requests for data. But also think about collaboration and coordinating your responses regionally, perhaps through your regional ICS, with your neighbouring trust, with your gold commanders. Deal with all investigations and enquiries in the usual way in terms of duty of candour. Duty of candour does not fall away simply because we are in a public inquiry. In fact, duty of candour is probably, should be at the forefront of all of your minds in terms of the way that we move forward. Whilst the inquiry will set and direct the scope of disclosure that they require, be very candid in your communications with the inquiry. Be honest and transparent and reflective, because failure to do so will result in criticism. I've put a quote there from point 21, learning point 21 of the Hillsborough report. But if I'd prepared these slides after last week, I could have quite easily been quoting from counsel to the inquiry, to the Grenfell inquiry, about the lack of candour that was noted during that process. It's really important that we recognise the need to support our workforces. Do not underestimate the impact that the COVID inquiry will have on your workforce, whether it be reliving experiences, findings of fact which will be taken as collective criticism against the workforce who worked so tirelessly and so hard throughout the pandemic. So that feeling of collective criticism. So consider what wellbeing and support services there are and how you can best inform your inquiry team. Provide information about what their roles and responsibilities are so they fully understand where they're going and that they're on board with you as you work through this process. And reassure them that any role for frontline workers is likely to be limited to sharing their experiences and that there will be the availability of support earlier on. But remember, each and every one of you in this room is a senior personnel working within the healthcare sector. You're not immune from those pressures and feeling those criticisms. So look after yourselves in that too. And finally, and very important from my perspective, learning. The inquiry report will make recommendations and it's important that they're implemented. But even with interim reports, those reports are not going to come for some considerable time. There is no need to wait for you to start your periods of reflections and looking back and to see what lessons that you can perhaps learn and what changes you can perhaps implement from this early stage. Don't miss those opportunities for look back and work collaboratively across your ICS to make sure those lessons are shared and implemented, particularly given that your ICB will now be the emergency Cat 1 first responder moving forward for anything in the future. If you want to pop by and speak to me later, I can share some of the experiences of how you can approach your document collation that best informs learning at an early stage. And then I've just included as a final point there, just remember the PSERF changes that are coming up, the Patient Safety Incident Response Framework that's just been launched and which you will all have to have implemented in terms of your replacement for the Serious Incident Framework by next year. And this, of course, is going to be looking at your individual held data, and it may be that some of the learning from during the pandemic might be in your own improvement plans. So I think, I'm sorry, I think I've gone on for far longer than what I was supposed to there. But in terms of what we've looked at, we've covered what you need to know about inquiries, what we know so far about the Covid-19 inquiry, the inquiry's power to gather evidence and some of those important strategic consideration. So the floor's now open to all of you for any questions, discussions or reflections that you may have.
Thanks, Liz, for a really thorough overview. So, colleagues, we still have got a fair bit of time while we've got Liz as our expert in the room. So if you'd like to raise your hand or put anything on Glisser, either to ask a question or to comment on your own experiences of preparing for this inquiry or indeed of other inquiries. There are some good questions coming through on Glisser, which I'm going to come to in 1 second. First, there's just a quick one for me. I just wanted to replay the steer I took from your presentation, just to check I've heard this correctly. So it sounds to me as if we don't know who could be called. Some specialists I've spoken to have said they don't think many providers will be, but the fact is we don't know. So the steer I took from your presentation there was that there are some steps you would suggest everyone takes so that you're in the best position possible if you are asked to give evidence.
Yes, I think that there is a reality that we have to all look at. Not every provider is going to be asked to provide data because that would simply overwhelm the public inquiry when you look at the amount of data that you each hold. There will be a huge amount of data that will already be available and centrally held. You are all feeding in statistics to the Department of Health, to NHS England during the inquiry. A lot of that information, therefore, has already been collated. However, when you go to some of those key lines of inquiry, when you go and look at those 12 points that are going to be considered, it is going to be difficult for the inquiry to properly examine some of those issues, some of those themes, without coming to providers. And who are they going to come to? We would all love to know. It may be that they come within an ICS area, a regional approach. It may be that they go to some of the organisations where we know regionally they had particular issues. But what you can't do is simply sit back and do nothing in the hope that you're not going to be one of the organisations who are approached. Because if you do receive a Rule 9 request, the time frame for complying with that is going to be rather tight. And I say that, you know, that's not me being, you know, a bit cautious about this. It will be tight. And there will be an awful lot of data. And the trust that I've been working with, the data that can be collated just at a gold command level is significant. If you then start going to go to hospital site levels and then ward levels, the data is just unfathomable. So there is a degree of data, and you at least need to understand your data spread and what you might have should the inquiry make those requests from you.
Thanks, Liz. Okay, I'm going to turn to Glissa then, because there's some really good questions coming through here. So kick off with an important one. So going back over the modular structure, will the inquiry review the decisions made prior to the pandemic? So that's failures of preparedness. And will it look at the decision to discharge patients into care homes? And there's a sub-question really about how people will be held to account and how the findings might satisfy the public.
Preparedness is being dealt with as module 1, but it's being dealt with at a high level. So have there been missed opportunities effectively to learn from previous incidents? In terms of module 3, what they're going to look at from the date of the pandemic, being alerted at the start of we've lost so much time now. We're 2019 or 2020?
2020.
Right through to the date that the public inquiry was announced, so June of this year. So they're covering a really, really big time frame.
Yeah, and they will look at the decisions to discharge.
Oh yes, the decision to discharge. It's covered within module 3. If you go to the key lines of inquiry, it is the NHS's decision making with regards to discharge. It will also come up again when there is a further module announced, which will look at care and social care providers.
And they're also looking at decision making, aren't they? So where decisions were taken, i.e.
Yep.
Department of Health, NHS England.
And that's really important. Miriam makes a really good point there. When you're being asked to provide information, when you're being asked to engage in this, not all of it will be your decisions, your accountabilities. It will be decisions that were made at other levels. It's when you go and really cut through some of those key lines of inquiries, it's saying which of those were decisions that were dictated by us at a local or a regional level. Where did we, or some of them in terms of how did we implement those recommendations and guidance at a local, regional trust level.
Thanks, Liz. Okay, I've got some quick fire practical questions, but they're all really important ones. And I don't know the answers. Is a Rule 9 request likely to be specific in terms of what it's looking for? So will it be all policy documents relating to, say, visiting, for example, so relating to one topic, or more likely to be along the lines of literally everything you hold in relation to X?
No, it will be specific. A Rule 9 request will be specific as to what is being sought from you. It will not be, here are the 12 key lines of inquiry, give us everything that you've got. Because however large the inquiry team is, and they are large, as you'll have seen, that are dealing with this, they simply won't be able to manage that amount of documentation. There will be a protocol, not only in terms of what is wanted, which will be specified in the Rule 9 request, but there will then be a protocol about how you collate that information and provide it to the inquiry. So watch this space.
Thank you. And a few people interested in WhatsApp documentation in particular. So what to do if it's no longer available, but someone's requesting it. I don't know if you've got any other observations around WhatsApp, because that's Slightly new to some of us, isn't it?
Yeah, yeah. It's a tricky one, and I'm not going to go into the world of social media because I don't even know how it works properly in terms of what can be accessed by who, in terms of those protections of WhatsApp messages. What you need to be telling your staff is if they have got anything, that they should be preserving it in case it is asked for. Yeah. And that's the best way forward at this stage.
Helpful, thank you. And just thinking about timescales, you've mentioned a couple of times, Liz, the timescales will be tight. That's particularly if people are asked for information, isn't it? So can you expand on that at all? Do we have any sense from previous inquiries if it's like a week or a month turnaround?
It's not going to be a week, but I think you will only get a matter of weeks. There will be that expectation that you know that it's coming. And consequently, therefore, you should have a degree of control over your data that may be relevant data to the inquiry. How long you get will depend upon how much information they are seeking from you. And it is possible, and I say possible, if you are not able to comply with the timeframe set by a Rule 9 request to get extensions on them. But you have to be open in terms of your communication with the inquiry team from a very early stage and not go run into them a week, 2 weeks after it was due for submission because you're desperately trying to avoid a Section 21 notice. They are amenable, but I think you will be looking at weeks as opposed to months to provide any response.
Helpful to know, thank you. So lots of questions here, colleagues, so I'm going to try and get through as many as I can. Just keeping with time frames, seems to me this inquiry is moving at some pace. Obviously we can't give a crystal clear answer, but is there anything more we can say about the time frame as a whole? What's your instinct on that?
So what we know is that during the course of 2023, we are told at the moment that Module 1 hearings will start in the spring. Mm-hmm. We are told that come summer, Module 2 public hearings will start. So I think we can take it from that, perhaps that Module 3 public hearings will start at the very beginning of 2024. Good indication, I think.
Yeah. It's still quite pacey though, isn't it?
Look, if any of you have been involved in a public inquiry, what do we know? We know the average is 4 years and 9 months, I think, for an average public inquiry. And they're where they're looking at discrete issues within one organisation or one theme. So that in itself may indicate at what level they're going to seek disclosure, because they have to do it in a proportionate way. And if they're telling us that the inquiry will not be allowed to drag on and drag on and drag on, then it may suggest that the level of data over and above the scientific reports being commissioned, the research available at the moment, all of that centrally held data that you've already submitted to NHS England, the Department of Health, it may be an indication that they're not going to seek a whole raft of data at a provider level, but it may not.
Thanks, Liz. Okay, and another specific, which I think this could apply to a lot of trusts because we have a lot of change, a lot of turnover. You mentioned board level director accountability. How best might people handle it if there's been a change in executive level during the pandemic?
In terms of collating information, in terms of, look, where your board is going to come in terms of, if we take the evidence side of it first, it's going to be who were those key decision makers, who were responsible and accountable officers at the time, who may be the appropriate people to provide a statement if requested to the inquiry. Whoever you are appointing at your board level to lead, it would be best that they were within your organisation during the height of the pandemic, because they will understand the challenges that were specific to your organisation at the time. Now that, of course, is going to be tricky, but there will be somebody, I am sure, on your board who remains in post, who was there during the height of the pandemic.
Thank you. And there's some interesting comments also on Glyssa around the themes that the inquiry might look at, which you talked to us about at the beginning of your presentation, Liz. So a kind of comment about the importance of not losing sight of social justice and the focus on equality in particular, which I think you said would be at the heart of how the inquiry explores what has happened in recent years. And then a specific question about whether the inquiry will look at the support that was put in place for the workforce, particularly around well-being and workforce mental health.
We are told that those stories and those experiences of your staff are going to be really important, and they are going to be part of the listening exercise that is run in parallel to the inquiry. And the impact of the pandemic is one of those 12 key lines of inquiry, the impact of the pandemic on your workforce. So yes, those things will be looked at, and they will be important, and they will be important as that key line of inquiry, but also part of this parallel listening exercise.
Really helpful, thank you. And any advice, Liz, on how we might prepare individuals if they are called to give evidence? How much notice might we have, and what sort of support might be helpful to them? Probably veering slightly out of pure legal advice there.
It is unlikely that somebody will be called to give evidence unless they've been asked to produce a statement.
So probably unlikely from a provider.
So you are going to have that involvement with somebody from an early stage, and the availability of support should you require external support in terms of feeding into that preparation of the statement alongside the review of the available documentation.
Well, thank you. We've covered a lot of ground in today's session, and there are a couple of questions here also about NHS providers' response. So we've surveyed you about what you would find most helpful from us, and the response was that you really valued briefings like these. So we'll continue this series working with Hempsons. We've also been working with some other legal firms to offer this kind of insight really into how the inquiry might run. We'll continue briefing on the inquiry in written form as well. We have tried to shape the terms of reference when they were out, and we'll most likely submit evidence. We are still deciding ourselves whether to apply for core participant status, which is one of the questions I knew someone would ask me. But as Liz said, it's an important decision. You have to weigh it quite carefully. So the honest answer is we haven't decided yet, but we will keep you posted as to what we think is best to do. A lot of representative bodies have sought core participant status. They tended to be in the social care sector thus far, but we're thinking about it really carefully, as are the Confederation. So I'll keep you posted on that. So we've just got a couple of minutes spare, so I think we might just squeeze in one final question, and then I'll say my thanks to Liz. So this is another practical one, back to WhatsApp, I'm afraid.
Do you know, I really don't even know how WhatsApp works.
How can that be, though? I think we need to give you a lesson. Some of these are relevant to us. We had a lot of WhatsApp chats going on during the inquiry as well. Could we be prosecuted for losing a phone? Somebody has asked. I think not, because they wouldn't know that you'd lost it in the first place. But lots to think about. So thank you, everybody, for your comments. Lots of kind of thematic questions and comments there, and lots of detailed, very practical questions as well. So huge thanks to Liz for sharing her expertise with us. My real takeaways were that there are lots of unknowns around how the inquiry will unfold, but we know it's going to impact on staff in terms of the public narrative. We know that any provider could theoretically be called at relatively short notice, so there are some helpful steps we can all take to prepare. And of course, it will remain a priority for NHS providers, and we'll keep on with these sessions, which have always been really well attended, and with briefing you as to how it unfolds. So I hope you found that useful. Thank you so much for your time. We are just about coming up to time now at 1:10, and I can imagine you're all very hungry, and I think lunch will be being put on and prepared downstairs.
I'm around for the next 2 days on
Hempsons have got their stand downstairs, so do pop in and see them and ask any other further questions as well. Thank you so much.